Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. A virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 282 of our Pharmacotherapy MCQ series, which majors in dyslipidemias, atherosclerosis and coronary heart disease. The first question reads, JGP is a 63-year-old white woman who implemented lifestyle modifications for her dyslipidemia 7 months ago and is in clinic for follow-up. She has a history of gout, chronic non-ischemic heart failure with a left ventricular ejection fraction abbreviated as LVEF of 26%, and diabetes mellitus which is diet-controlled, as well as a 20-pack-year smoking history. She quit smoking 5 years ago. Her medications include lisinopril, furosemide, metoprolol succinate 25 mg once daily. Her vital signs include BP 124 systolic 80 diastolic and a heart rate of 75 beats per minute. Her laboratory results are as follows. HDL cholesterol of 64 mg per deciliter. LDL cholesterol of 101 mg per deciliter. Triglycerides of 98 mg per deciliter, and T/C of 185 mg per deciliter. So my question to you is, what is her 10-year atherosclerotic cardiovascular disease risk based on the calculator? The components of the risk calculator that impact JGP include her age, gender, total cholesterol, HDL cholesterol, and diabetes mellitus. She does not have hypertension, and smoking does not count as a risk factor due to the fact that she is not a current smoker. Therefore, her 10-year atherosclerotic cardiovascular disease risk is 7.1%. The next question reads, based on her risk, what is the most appropriate next step for JGP? JGP falls into the statin benefit group of a diabetic with a 10-year risk of less than 7.5%. The guidelines recommend that she be initiated on moderate-intensity statin therapy. Therefore, any statin dose within this category that would lower LDL cholesterol by 30% to less than 50% would be appropriate. At this time she is not a candidate for a high-intensity statin, despite having diabetes. The decision is made to initiate simvastatin 40 mg daily. The next question reads, 4 months later, JGP is admitted to the hospital with atrial fibrillation and is started on amiodarone and apixaban 5 mg twice daily. What medication modifications should be done to JGP's medication regimen at this time? The addition of amiodarone to her medication regimen necessitates a reduction in her dose of simvastatin to 20 mg daily. This dose is still within moderate intensity range and is acceptable. The other option would be to switch her to different statin that is either not metabolized by CYP3A4 or metabolized to a lesser extent than simvastatin. Reasonable choices of statins would be pravastatin 40 to 80 mg daily, fluvastatin 40 mg twice daily or XL 80 mg daily, atorvastatin 10 to 80 mg daily, pitavastatin 2 to 4 mg daily, lovastatin 40 mg daily, and rosuvastatin 5 to 40 mg daily. RPR is a 62-year-old male, with a history of coronary heart disease bypass 2 years ago, diabetes, end-stage renal disease abbreviated as ESRD, on hemodialysis Monday, Wednesday, and Friday. He is on lisinopril 10 mg daily, atorvastatin 40 mg daily, aspirin 81, metoprolol succinate 50 mg daily, insulin, and calcium acetate 667 mg 3 times daily. His BP is 136 systolic, 82 diastolic. Hemoglobin A1c is 11.6%. The weight is 132 kg. The height is 5 feet 10 inches. His fasting lipid panel is as follows. Total cholesterol is 250 mg per deciliter. HDL cholesterol is 30 mg per deciliter. And TG is 450 mg per deciliter. So my question to you is, what would be the most appropriate treatment for RPR and his dyslipidemia? While RPR does have elevated triglycerides, per the endocrinology and AHA guidelines, pharmacologic therapy is not indicated at this time. The most important intervention for RPR is lifestyle modifications. Controlling his diabetes and losing weight can successfully lower his triglycerides as much if not more than pharmacologic therapy. The next question reads, if pharmacologic therapy were initiated on RPR for his hypertriglyceridemia, which agent or agents would be the most appropriate? All fibric acid derivatives undergo renal elimination and none of these agents are approved for patients on hemodialysis and are therefore not a good option in RPR. Omega-3 fatty acids would be the best option to use in combination with atorvastatin that he is already taking. The next question reads, JOS is a 46-year-old male with a history of hypertension and diabetes. He presented to his primary care physician with a chief complaint of abdominal pain that began 2 days ago and radiated to his mid-back. He also has some vomiting. All of his vital signs were within normal limits. On physical exam he has tenderness over his abdominal area that is more severe in the epigastric region. Pertinent laboratory values include an hemoglobin A1c of 13.6% and the following cholesterol panel. Total cholesterol 467 mg per deciliter, HDL cholesterol of 30 mg per deciliter. TG of 1,872 mg per deciliter. LDL cholesterol was unable to be calculated. Amylase of 325 units per liter, and lipase of 3,265 units per liter. Following acute management of his pancreatitis, what would be the most appropriate treatment for JOS? This is an individual that is high risk for pancreatitis as well as atherosclerotic cardiovascular disease. His risk score using the new risk calculator based on recent guidelines reveals a 10-year risk of about 18.6% and a statin is indicated. Additionally, the endocrinology guidelines define a triglyceride level of equal to or more than 1,000 mg per deciliter as severe and the AHA guidelines define a level equal to or more than 500 mg per deciliter as very high and that pharmacologic therapy should be initiated. JOS should be initiated on a statin and a fibric acid derivative, or two different agents to lower triglycerides first, such as omega-3 fatty acids plus fibric acid derivative to get triglycerides down, and then consider the addition of a statin. The next question reads, what are some considerations when using fibric acid derivatives in combination with statins? The risk of adverse effects of statin-fibrate combination therapy is dependent on pharmacokinetic interactions that alter statin metabolism and clearance. One of the most significant drug interactions with statins and a fibric acid derivative is the combination of a statin with gemfibrozil. Gemfibrozil inhibits glucuronidation, which is an elimination pathway of all statins with the exception of fluvastatin. This interaction can lead to increased concentrations of these statins, increasing the risk of toxicity. In contrast, fenofibrate appears to have a minimal effect and is considered a safer alternative. The use of gemfibrozil with simvastatin, pravastatin, or lovastatin should be avoided. The combination gemfibrozil with atorvastatin, pitavastatin, and rosuvastatin may be considered if fenofibrate is not an option. However, lower doses of statins should be used to minimize adverse effects. Labeling for rosuvastatin suggests limiting the daily dose of rosuvastatin to 10 mg daily when used with gemfibrozil. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 283.